Welcome to Vision 2020 USA's Spotlight Series. Today's topic, the SEEN Lab Approach to Preventing Blindness from Diabetic Retinopathy, featuring Dr. Kristen Nwanyanwu, Associate Professor of Ophthalmology and Visual Science at the Yale School of Medicine. The Spotlight Series is hosted by Dr. Rajiv Ramchandran, an Associate Professor at the Flom Eye Institute at the University of Rochester, and Dr. Dean Van Asdale, an Associate Professor at The Ohio State University College of Optometry, leading members of the Vision 2020 USA Executive Committee.
We're very honored to have Dr. Kristen Nwanyanwu, who's Associate Professor of Ophthalmology and Vision Science at the Yale University of Medicine. She will discuss her SEEN lab approaches to preventing blindness from diabetic retinopathy. She has a great webinar series called Eradicate TRD, which as a fellow retina specialist, I'm always excited to learn how to do because we have to end this disease in our community. And I've seen too many of these cases the last decades that I've been a retina specialist and really trying to find out how do we end this. And diabetes is our theme for this year for Vision 2020 USA because I don't know if many of you know, but CMS has put out a proposal to do away with diabetic eye exams as part of the star quality rating for health insurances and care plans. And that just came out in January. And there's some back and forth. Some insurers are like this metric, is something that we can't meet. And others, like boots on the ground, like us here on this call, pretty much are like, no, we can't get rid of it. Yes, it's not perfect, but it's the only metric we have in public health for eye health, and we can't let it go without having a good replacement. So this is what we're talking about. So just a brief introduction about Dr. Nwanyanwu. She is recipient of the National Eye Institute's Directors Award and Sheeman Award and the Secretariat Award from the American Academy of Ophthalmology. She was also awarded a Young Alumni Service Award from the University of Pennsylvania, a Perelman School of Medicine in 2023, and where she was elected to the AOA Beta chapter in 2025. She serves as advisor on the University of Pennsylvania Medical Alumni Advisory Council as well. But her passion is for community engagement and community health, which she developed as an undergraduate at the University of Michigan, and then went on to medical school at the University of Pennsylvania and retinal fellowship at the University of Illinois in Chicago. At Yale, she has gotten a Master of Science, and through the selective Yale Center for Clinical Investigation Junior Faculty Scholars Program, which she completed, she's been really developing a great program for community outreach, as well as being a full-time retinal surgeon, a busy retinal surgeon at that. So with that, I turn it over to you, Dr. Nwanyanwu, and lead us on.
Super happy to be here. I was like trying to reminisce about the first time that I had seen your work, the work that you do, Rajiv, and I think it was like in DC. I think you were presenting or something. I was like trying to think about it. But it's just great to have community as we try to highlight how important it is to decrease preventable blindness from diabetic retinopathy. And like-minded folks getting together to talk about what it looks like. This is my lab, and this is our approach to how we think about this. And I'm just looking forward to kind of level setting and getting through these slides. But I really want to hear, from you all, lots of experts in the room, about how we all should be thinking about what this looks like. So for those of y'all that know me, there's like some of this that may be familiar. There's some new sexy stuff at the end, but I hope we can nerd out about what comes next, because that's my favorite part about science, and that's my favorite part about the work that I do. I'm Associate Professor of Ophthalmology Visual Science. I have another job currently where I work with communities to try to figure out how to elevate community voices in our research portfolio at Yale as well. And this is my favorite thing to talk about. So Eradicate TRD is a concept that I've been thinking about for a couple years now, just not with the fact that it's a infectious disease that we can get rid of, but really that we shouldn't have them. Because living in America, people shouldn't get tractional retinal detachments. It's slow. It's a slow developing complication, and there's no reason that diabetes should be one of the leading causes of blindness. And what does that look like, and how can we manage that from an implementation science perspective? I am This happened to me before, and I should have chosen a different earpiece. So I have a company, and I've been a consultant before. That's what this is. We're not talking about any of that. But what we're going to do is talk about a shared path towards preventing blindness from diabetic retinopathy. This is one of our study participants, high COVID time, who really personifies how we're getting together to try to figure out what to do. This is a slide I've been showing lately, particularly now in these times where human progress never rolls in on the wheels of inevitability. If we're trying to figure out how to change and how to be creative and innovative about what it looks like to save sight, we can't expect to be kind of lulled into that. And so how do we as, advocates really put together the right argument, the right systems, the right interventions to make seeing well with diabetes a feature? So we're going to talk about opportunities to advance equity, and then we're going to talk about strategies to advance equity and a little bit of eradicate TRD at the end. So this is one of our participants. I mean, nobody wants to be blind. I watched what my sister went through, and I think of her living in darkness for so long, and I'm like, I don't want to do that. And when we really try to elevate our participants' voices in our work to try to guide what we're building and what comes next, for our retina specialists, this is tractional retinal detachment, right? You can actually see rhegmatogenous component inferiorly, and this is what blindness looks like, and this is what we shouldn't have. And so trying to figure out how to put ourselves out of business and do other things, and try to make sure that we make systems to be able to do that. So when I thought about eradicate TRD, I said, what are the components, right? So as a scientist, we think about, what are the things that we can study, right? That's randomized controlled trials or like piloting, or like, what does the science say about what we should be doing? But as we know, it's not enough to just have, proof that we do something. What do they say? It takes, 17 years to get something from the science all the way to actual practice. So that requires a lot of our other people here. I see Dr. Todd here and others. Like, it requires advocacy. It requires saying these are the things that are important. Here's what we need to do. It also requires incentives. We talk a lot about with conversations about a lot of the things that are happening are features, right? Our systems are designed to allow this certain amount of blindness to occur. And so what does it look like when we interrogate those systems and design new ones to improve things? This is from our Sentinel kind of guideline paper from Dr. Elam about health disparities. And I still talk about health disparities and health equity, partially because that's my being, that's my research. But I think when we talk about it, it's really important to have it all encompassing. So here in this document, in this thought paper, they really talk about race and ethnicity, which is what we think of and which is what our news outlets want us to think of. But we're also talking sociodemographics. We're talking about location. There's a lot of sexiness about rural health these days, which is also health disparity, which is really important to think of, age and sex and gender, and then across the spectrum of eye disease in general. This is my throwback slide because I love to remind people that health disparities in diabetic retinopathy are old, right? There's papers here from the 90s. Ever since we could calculate this, we've known that there's discrepancies and disparities on multiple levels, right? So less privileged sociodemographic census tracts have higher incidence of diabetic retinopathy. Neighborhoods have been shown to have increased A1C even after accounting for all the factors. So we know social determinants, we know those things to be true about where you live, where you work, where you play. And then what are we going to do about it? Which is what I was asked when I started my career in this world. It's like, yeah, this sounds great, but then what? So this is my takeaway slide that I love. Black, Latin, Native, less privileged individuals are screened less, diagnosed later, treated less, and go blind more often. And that is actually from A to Z, from the beginning of how we think about diabetic retinopathy all the way to the end. And we actually just drafted a paper that's a meta-analysis that's looking at all the different aspects and where those drop points are and what are the data that we have to be able to intervene appropriately, which is really exciting to have the data be able to do that, but also pretty sad that that exists in that way at so many levels. So what are our opportunities? And I think I saw Paula Ann here. And so when this came out, Paula Ann Newman, Casey, and I, you would have thought that Taylor Swift dropped a new album, or Kendrick Lamar or Bad Bunny, right, dropped a new album, because we were delighted to see this work. And what it was is in 2016, National Academy of Sciences built this model for like, how do you improve population eye and vision health? And finally, we heard our song on the radio. We're like, wait, this is who we are. And as budding researchers, this is 10 years ago, we were delighted that this was like something that we could do and follow. And these are the things that we still know to be true. So, to approach improved eye and vision health and health equity, here are the things that we do. You all know public awareness, generate evidence. What's the collaborative nature of it? How can you be population centered? What is community tailoring, right? These are the pieces that we've known for public health, but to see them in the setting that makes sense for our life's work was really, really special. And then we got this conceptual model that really double tapped on something that's important to me when we're talking about community engagement. So our lab does a lot of community engagement, and the legendary, Eve Higginbotham offered, this to us with regards to how do we, take a community through the steps of being able to center that work, center communities, and create kind of those bidirectional pathways, which means how do we hear what communities need and actually do them in a healthcare setting? And so, public health scholars got together and National Academy of Medicine and gave us this framework for how to be able to do that with the important drivers of health and drivers of change in health in the context of which we're dealing with now, whatever social, political, racial, economic, historical, and environmental context that we're in, which provides hope and the ability to be able to use this going forward. So our lab took this true to form, and we do this in 3 ways. So we do community engagement and asking the question, how can community members give us the answers? So I always tell my Yale colleagues that I don't think that the answers are at Yale. I think the answers are in community. Because if they were at Yale, we would have done it already, right? So how can we figure out what we're actually going to do and how to make sure to keep people seeing? I nerd out about data. So I was on that health equity task force on the data team because our data will help us to be able to say the things that we know to be true in a way that is that you can share in a helpful way. And so you'll see our lab publishes with some of the source data with Dr. Stein. We've published using Optum data. We publish using our local data to try to ask and interrogate what are the things that we're missing and what can we look for in the data that are clues and threads to be able to get to the next step. And then implementation science, which is that science of can we take evidence-based solutions grounded in theories, models, and frameworks and actually do the things that we need to do. So how do we engage community members to help us? So for those of y'all familiar with this concept, you'll have to excuse me because I like to just bring this up as a concept because a lot of people aren't familiar with what community engagement is and how important that is. And also how old this concept is. So this is from 97 and it predates that. We're thinking about how can you collaborate with communities to improve the health of their own community. And there's several principles of this. This is the social ecological model that a lot of public health folks might be familiar with. And I like it because it just makes a lot of easy sense. When you think about, treating someone or a population, there's human, and then that human has relationships with other humans, hopefully, even virtually. And then you build those communities, and those communities have societal impacts and relationships. And how do we think about different levels of how to interact and how to engage to be able to impact someone's health? And Paul and Ann and I kind of interrogated this a long time ago with the community engagement continuum and how we do that in eye care. And at that time, we were trying to figure out what level in the spectrum eye care exists. And I mean, what's beautiful about eye care is that we do a lot of outreach, right? There is a lot of consult. We involve communities. And then the question is, how do we get that collaboration and even to shared leadership where, we're building things together and identifying what is our path forward together? And these are some of the principles from that. I'm just going to highlight a few. I mean, I think the trust is the most challenging one. To be able to build those long-term relationships are hard to come by, especially on like grant timeline or funding timelines, but are really critical, especially when you're trying to make change. Self-determination is one that's really critical in terms of empowering communities to be able to believe that they are in charge of their own destiny. I think that piece is really important, and respect of culture. When you've seen one community, you've seen one community. And so how can we show up with humility and ask the questions to allow us to be able to help usher a community to their best vision? So what are the strategies? So here I'm going to highlight the SEEN program because this is who we are. But I think what really is important about this is even more than the SEEN program that we created is the methods. So what are the methods that we use to be able to develop this program, and then how we're interrogating that framework going forward to figure out what to do next. So here's a picture of us out in community, which is our favorite place. We don't do this in 2 feet of snow. Our community members tend to be inside. But in the summertime, this is where you'll see us, right? Engaging the New Haven community. And we engage community members to try to figure out what this should be. So here's the SEEM program, and we'll kind of talk about the layers. So it's a risk stratification model. Risk stratification, I think, is really important in diabetic retinopathy care. I always talk about my humans that are usually demographic, 7-year-old, usually 70-year-old woman, hemoglobin A1C 5.5%, who comes every year, probably to the day, to their appointment to make sure their eyes are okay. That's not who I'm worried about. And so trying to figure out how to dedicate the resources, the people that we're worried about, line up with the things we know about communities, we know about health, and navigate them to their best vision. So when we started this, I had a medical student that helped me to think about what are the things we're missing in screening. And this is what we built. We built it based on the socio-ecological model we showed you earlier. And these are the quotes from our participants. And here's some things that they thought were important. And this was published in 2019, and we've spent the last 7 years really interrogating what we found. So we have lots of different cohorts of humans that we've asked very similar questions. We've had reflect on these issues in Spanish and English. We've had people of Asian ancestry. And so hopefully our next iteration of this will be this offering on a higher synthesized theoretical level so we can really think about how this impacts folks. But just kind of to get to the nuts and bolts of this, I didn't think I needed it. And a lot of times when I go to the doctor, all of a sudden I need stuff. And I didn't want that to happen. I wanted to think my eyes were going to be okay. And so here are the things that come up. And vision status and competing concerns are really important. As you know, if other things are happening around someone that needs eye care, it's going to be a challenge. And here's some challenges that came up in our conversations. Also, the emotional context and the way that we coded this doesn't have a direction, right? And so I think what's interesting about this particular theme is that fear can have 2 separate behaviors associated with it. So some people are so afraid that they want to go to the doctor every day and like get you to take a picture of their eye and make sure they're fine, even though you tell them pathophysiology of diabetic retinopathy doesn't work that way. Fear could also make someone never want to have their eyes evaluated because they're worried that they have something. And so how do we think about and how do we identify who has what relationship with eye care, and then how do we incorporate that into our systems? Also, vision status, you know, we always talk about, and I think is a really a challenge in diabetic retinopathy care, is that your vision is fine until it's not. And which makes vision a challenging outcome. And when we think about designing studies, because a lot of times people are 20/15 until they're counting fingers. And so what does it look like to be able to get the person to the right place at the right time in an operation that'll allow them to be able to live the life that they need to live? Other things is, how do we leverage this, the importance of vision status? I mean, Adrian Scott has a beautiful paper that looks at the kind of dreaded outcomes from patients. And, you know, number 1 was they didn't want to have cancer. And number 2 was they didn't want to lose their vision. And that importance shows up in so many places. And so how can we leverage that importance of vision status with the fact that in diabetic retinopathy, vision changes is a late symptom? And so how do we put that together? I think when I've seen this most beautifully done is in the MySight work at a federally qualified health center in Flint, where they leverage glasses to encourage participants to come back to their clinic and to their appointments. And I think like trying to figure out what are the carrots that are already aligned, that already make sense for our participants is really important. So institutional and structural characteristics, resources are always a challenge. We have a lot of papers on transportation because it's such a big deal. Cues to action. I loved this one because my primary care colleagues, I told them, look, they said that you're telling them to go, which is awesome. Also, knowledge creating experiences. Our patients love YouTube. I mean, the Prevent Blindness people on here, they know that, right? People love to be able to get their own information and digest that themselves. And then also culturally, we think about the in-clinic experience, right? We have institutions that may not have always been the best neighbor. And so what does it look like for the institution to, show up as a good partner and to make patients feel happy and whole no matter when they show up or how they show up? And so here is a quote: "I was in a tough place. I was on the streets after squinting for 2 years to see everything, and I finally went back to the doctor." So implementation science. So this is our format again, and how we built this is fun. It's a fun story. So we used the TICD checklist actually after seeing a talk at ARVO about implementation science in eye care. And I'm like, this is amazing. I should do this. And this is what happened. So this is a very long checklist about determinants or the barriers to and facilitators of a certain challenge. And so we did that, and we matched those implementation interventions to the determinants that make sense from the paper that you just saw. And that's how we built the SEAM program. And the SEAM program has a step to identify people at high risk. And we talked about a little bit about risk stratification. And risk stratification is a tool that is leveraged much more often outside the States, most often in places that have better data and that can leverage their data to figure out who should be where. But so we said, can we leverage our data to try to figure this out? And this is a study that I did, oh my gosh, it says 2012, with Dr. Stein when I was a resident at Michigan, where we looked at the risk factors for progression to diabetic retinopathy. And so I carried that with me of trying to figure out what are the characteristics that we can find that are on the way to our high-risk individuals and put them all together. In that study, we demonstrated that people with non-healing foot ulcers had increases of progression, and that for every 14% increase hazard, for every 1% increase in A1C. And so when I think about holistically how to think about risk stratification, those are some of the checks that I think just anecdotally when I'm seeing my patients. So we did the same thing. The database that we used was the Optum database, so insured people with jobs. Our community here isn't always that way. So we did our own, and we used a AIC criteria to try to figure out what was the best model. And that's actually what we used for our SEAM program. But there's lots of different versions of risk stratification. People have used UKPDS. The ADA has the retina risk model that they used. Lauren Daskovich at LA County has a really sexy AI model that they've been using to risk stratify people in the LA County system forever. So there's a lot of beautiful options for this that we underutilize, but I think that's really helpful when we think about how to manage our resources. Education. So we really focus on co-design. So this was actually co-designed. You can see Osama's name here. He was a resident at University of Michigan, but he was before that my med student. And so he co-designed this video with community participants and retina specialists. And so we used this to educate our team members and our community members about diabetic retinopathy. And then navigate. So this is our community partners. So Project Access, their Project Access is all over the place, but they specialize in clinical coordination and patient navigation. So when we saw the need to try to figure out where everyone should go to get the things that they need and how impactful it was for our patients when they had a need, we partnered with Project Access to be able to deliver this service. So we did a SEAM program. The pilot was mostly Black and Latin population, 10% mean hemoglobin A1C, 80% of them reported a stroke. So it's a sick population, well appearing, which is also what I teach my residents about complication of diabetic retinopathy. So this also demonstrates how well people were seeing. So 2025 was still an equivalent, and you saw the characteristics of this population. And then, so I think, and also the population actually didn't have diabetic retinopathy in that time, which was great. So trying to figure out how we can find the people that we need that are at high risk and get them before they have a problem. Here are the needs that were identified, so you can appreciate here: food access, housing access, and health insurance, primary care provider, transportation. And what was really unique about this was that almost a third of our cohort had a specific need that was identified in our screening. And all the patients that had diabetic retinopathy had some kind of social need. And so this is a pilot, this is a small sample size, but I think that part is important. So we assessed clinical outcomes and program utilization, and we had people that completed the program and those that did not. And then we also did interviews with a sample of folks that were doing it, but also people that were participating as well. And we organized the themes using Regain in light of that first framework that we started with for the determinants. So here's some things that participants had to say that were really important to them, excuse me. So my A1C when we first started this was really high, and now it's down to 6 or under, and it was just a lot of it was that kind of companionship. They gave me an outlet, somebody cared, and how to get a hold of your own doctor. And it took so long, just to get the appointment. So how does that external context really impact how people are moving and seeing? And then also the vision status. I have a lot of issues and I want to keep my sight. And that's that other kind of hearing your song on the radio in the themes that your participants are saying. You're like, I hypothesize that this is important. But when you hear it, when you're building future interventions, that's something that really you elevate. So at this time, how do we support, right? People just need help and resources, and people love those interpersonal interactions. And I think that was important. We, were building a pilot study. So it was interesting to hear, how people encountered it and what they wanted to do related to that. So the things that we took away from this was, diabetic retinopathy is a complication of the margins. And so, when we see disparities, to me, that's what we're looking at, right? We're seeing certain aspects that are looking and working for a certain population, but we're missing the margins, and that's where the blindness lives. So what does it look like to center that and figure out what we should do next? And we did identify high-risk individuals with excellent vision. For any retina surgeon, they always say, I wish I would have seen you sooner. This is that population and our ability to be able to do that. And then how do we identify what are the key components to scale? So our team right now is just looking at what are the pieces that matter most, and then how do we map that to some of the challenges that we had doing the study to be able to figure out how to allow and elaborate and do this at scale. We have a grant under review about how to do that. So now I'm just going to pivot a little bit because we have another opportunity that we've been working on. So we have a community co-designed digital health tool. And this is the design that we thought of when we started this was, once again, what are we missing? And is there an opportunity to work and build a digital health tool that would help this specific population? So we partnered with the Chill Lab, which is an amazing user design lab out of the School of Public Health led by Dr. Tarika McCall. And we partnered to say, can we build something that makes sense for this specific set of population? So we've published a couple papers on this, but just for most people that aren't familiar, because I was not, we held focus groups. And in those focus groups, we identified what are the themes or what are the things that people are interested in. And we each took our notes and we mapped them into what it would look like as an attribute or as a characteristic or a feature on the digital health tool. And so that's this piece. So I just love this screenshot because it's like a digital post-it notes, right? And so you can see I'm purple, and you can see the different places and how we kind of put those together to be able to say, okay, what should it have in it? And then we organize those into a design application, and you can see your x-axis here is easy to difficult, and your y-axis is, low to high. What's the potential for impact as well? So we map the user journey using this concept called persona, which is really an intended user biography, right? And so companies do this all the time when they're making prototypes and other things, and they say, all right, this is our human, and here's her concern. And what does it look like for us to be able to show up in that way? And so we use this construct to be able to build the tool. And then we took it back to our community partner to ask them how we can iterate. Like, what should it be? What should be in it, right? So, some of the things that they love the recipes. Like, how do you build culturally relevant recipes that make sense to me, that taste good, right? health tracking. They want the metrics, gamification, right? Can we do something on the eye test that helps them to like try to track what they're doing and what they're seeing, but that won't make them seem that they're okay if they don't go to the eye doctor? And then what does the chat look like? Like, what is the chat? What is in there? What data do we have access to? What LLMs will we need to be able to answer the questions that our folks have? And then what's the interface? Like, what can we interact with, right? Can we interact with my chart? Can we interact with your watch? Can we interact with all the other data that a lot of people are getting to be able to make something that's useful for these folks? We are still iterating on this, which is super fun. I stay in worlds that I'm unfamiliar with, so that part is really exciting to me to try to figure out how to do these things. And I have the most gratitude about the fact that these data and the beginning of these data started in a community that is oftentimes the last to get things. And so I love the fact that we started there and we're continuing to work with them to figure out what comes next. So if we circle back to eradicate TRD. So talked a lot about science. Sorry, that's who I am. I nerd out. I'm at Yale. But I think the other pieces are just as important, if even more so, right? And so, advocacy, just a slide on the we work. And so, Health Disparities Task Force showed us the roadmap, right? And access to eye care, diversifying the workforce, healthcare literacy, leveraging data, like those things aren't different. We still have to do those things. And I think that's still the path forward for me. And I will continue to follow that model. And I think also for local, state, national government officials, taking those data and saying, here are the things that are important and putting in, conceptualizing it in ways that make sense to them, I think is really, really the reason why we have experts in this field. I think also is, identifying opportunities to increase access to care. And then what does that roadmap look like in community? So the Academy just recently presented the work in Delaware at a federally qualified health center using AI autonomous diabetic retinopathy screening, and the Knights Templar grant signed on to be able to do that and replicate that with the lens towards, can we, elevate the experiences there to be able to replicate this often, right? Can we do this? Because we know from the work of the Federally Qualified Health Center Task Force that federally qualified health centers don't have access to eye care, most of them. And that is where a lot of our blindness occurs in our populations that need us the most. So if we can align those goals and those shared values to be able to try to figure out how to leverage some of the tools we're really good at to deliver care in spaces that we're not good at getting, that feels like a great opportunity. Yale is working to be able to not only support some of the questions and the evaluations to help people kind of get those things up and running, but working towards hoping that will be one of the sites to be able to try and figure out what are the key components to be able to do this there, leveraging the work that has been done in federally qualified health centers, like in Flint and in public housing in New York, and a lot of the different opportunities. So this is my slide that says, what equity dreams can we make come true? Because I still think it's something that's aspirational for us to be able to think about, right? Who's left behind, and then how can we center that work to be able to do so? And oh yeah, here's Eradicate TRD. Oh, Alvaro this is my research assistant, made a really beautiful slide. So here's some stars that you may know that had conversations with us about the things that we care about, eradicate TRD. So you want to start a diabetic retinopathy screening program. We had Dr. Daskovich from LA. We had Dr. Sean, who helped to support the pilot in Delaware, and obviously Dr. Newman Casey that was on recently talking about her work in Flint. And then two is like eye care and the safety net. So what does the safety net look like? And when we think about eye care and how do we knit that up together with some of our colleagues in other spaces that have historically done better than we have in terms of supporting whole humans in their pursuit of their best health, and in our case, pursuit of their best vision. So this is our lab. This was our dissemination party that we threw. So we got a bounce house and healthy food, and talked about what are some of the things that we had worked on so that we could return the results to community members that were so helpful in allowing us to leverage their data to be able to ask hard questions. So this is the team, and you can learn more about the Scene Lab here, or you could just email me. And then that's it. I'm happy to take questions if you all have any. And again, thank you so much for the invitation.
Wonderful. Thank you so much, Kristen, for this great journey that you've taken us through all various stages of how you engage in community, and then you utilize the community know-how to see what's best for them, right? And so kind of bringing together both the community experts and also medical experts together to kind of make it happen. So was wonderful. What do you think the biggest challenge has been in sort of doing this? Like, if there's one thing that you say that's been a big obstacle, what do you think it's been?
There's so many. Okay, I think. Well, I guess we're going to have a category. I think even just if I think about my career, I think it is even people conceptualizing that there are challenges in equity in ophthalmology. So if you think about when I started, they're saying, oh, like you're going to do what? Shouldn't you be in family medicine? Shouldn't you be in these other spaces and places? Is there room for that? And then if there is room for that, what would we do? Right? Like, what would you do as an eye surgeon to be able to mitigate some of the challenges that we know to be true? So I think ignoring kind of that concept that, we are allowed to opt out of something that we can't unsee. So I think there's that. I think also after that, it was this idea that people want to go blind and that's why they don't come, right? And so I think a part of our portfolio is kind of debunking that, right? Asking those hard questions, because it's very easy just to say, oh, you didn't come back, you must not have wanted to see, right? But when you pull that thread about what layers and what is required to be able to do things on the schedule, as retina surgeons often ask, it's not an easy thing. And so I think being able to help people reconceptualize what it means to adhere and what it means to kind of participate in your own health is also kind of it was a huge barrier. I don't hear that as much anymore. I'm grateful. But I think there was a period of time where people were just kind of like, you didn't show up. I guess you didn't want to see, which is super easy from a provider standpoint, but not helpful from a patient standpoint. And then I think in terms of kind of structuring our like program and proposal, the infrastructure to be able to figure out subspecialty and population health is not easy. Particularly trying to figure out how do you design a proper system when systems are designed for bigger things, but you know that you need systemic help. And I think asking, those questions, so that's where I'm nerding out these days, is like, okay, when I build something, how do I integrate it into, my colleagues' work? How do I integrate it into kind of our health system fabric so that it can't be undone, right? I don't want something that's like slapped on top, right? How do I make sure that it's in the fabric and a priority alongside all the other things that we care about in a setting with limited resources and in a time where like not only science is under attack, but like health equity is under attack and institutions like mine are under attack. And I continue to work. So I
It's
feel
amazing.
grateful to have a job, right? I feel grateful to have a job and to continue to ask these questions, but it's not promised. So it's kind of like just double tapping on what is really important and kind of one problem at a time, and just kind of sharing and using the skills that we have and kind of spreading this gospel of what everyone knows to be true, but has just been paralyzed because what are we going to do about it? So yeah, I don't know. We have a whole list. I mean, we're having a like problem paper that's going to come out about this pilot and all the
Wow.
pieces and drama. Apparently, there's journals for that, so we're going to do that too.
Nice, nice. Well, I want to just to take a plug for Vision 2020. We do have a special session at Arvo that Dr. Michael Chang is going to be the opening speaker for. So we're very honored for
Okay.
doing this, and we're trying to talk about transforming data into action. Many of you who've spoken with us before are going to be part of the panel here. And with that, you have all this data that you're collecting. So all this. How do you translate that to the policymakers, like you're saying? Because that's the next step, right? Is your local, Chamber of Commerce folks and the state senators and others. How do you voice all this to them to sort of make the difference?
I have needed a lot of help with this, but when I see people that do this really well, it's really stunning. I've had the opportunity to work with Scott Haber and their team, and kind of watching them think about the pilot and what the pilot would mean, and in their conversations being able to say what's important. But my favorite example of this is Dr. Benshon, where he, took his cameras to his state legislature and took pictures of their eyes, and then talked about the pilot that they were doing in the federally qualified health center, which is pure genius. Like, I'm like, this is the best ever, because you want to leverage the things that everyone has, right, to be able to support what we know a subset of our population needs. And I just think really crisp, clear innovation like that is going to really help us, because honestly, a lot of the things, and we have a lot of shared values about getting well, right, and being able to see it. If we can kind of lock down and double tap on those shared values, I think that will allow us to be able to continue to move forward and really focus on what are the principles to being able to do that. But I think, those are the best. But I just finished the American Academy of Ophthalmology LDP, which was illuminating for me, honestly, because that's not my world. But what I really found helpful is even creating those relationships, like just the people that are asking, just say, like, do you know who to find? And I think that is so crucial and critical, right? I sent a message recently about, ICE to my legislatures with the worry and the lens of my patients aren't coming, right? And I'm a researcher that researches lapses in care. I need you to know that from my lens, I am concerned about what will happen to my people that are already at risk for blindness. I tell those stories, right? I write those stories, I send those stories. And I think it seems like there's this large conceptual thing that we have to all do. But I do think that just elevating the point of that simple thing, that simple anecdote, that simple, conversation you had, or that simple thing that you saw or heard, is really helpful to be able to shape what happens in real policy, which is mostly local. And finding out what are those levers to be able to pull in organizations like yours and others is really, really helpful. And I enjoy getting guidance on that, because even though I have like a background as an activist, that's how I started like rebel rousing, but this form of trying to figure out what to do next, I love to be able to take the lead of the experts and be able to say, all right, these are some things that I can do and that I will do, and getting the data to be able to support some of the things that make sense to you. Oh, Paul
Awesome.
Ann, is that a
Paul
real
Ann,
hand?
yeah, it looks like she has a hand up. Go ahead.
I'm like, is that a real hand, or are you just hanging out?
I'm not hanging out, I'm listening. And thank you, Dr. Nwanyanwu. As always, I love listening to you. You always just have a wonderful way of telling all of these things from people's perspectives who are having trouble accessing the system. And I think you've given so much voice, given people so many voice in these ways. And I always just appreciate listening to you. And I wanted to pick your brain in this really lovely audience full of experts and ask you, like, okay, we know that things are maybe, people are having some pushback against health equity at the moment, but let's pretend that isn't happening. What policy changes, or not policy changes is maybe too big of a word, what would you like to see institutions do in a concrete way to kind of integrate some of the things that you found work to bring people and help them stay in the system?
I think risk stratification is super helpful. And a lot of institutions have data. We just don't leverage it in that way. But they have to track it to be able to get reimbursed. So a lot of the things that are important that we know to be true, we have. And so trying to figure out how to leverage the data that institutions already collect to be able to figure out who we're worried about. And I think that was like a really low hanging fruit, you would think. But today I was on a call with the head of our, diabetes primary care, talking about the challenges in that interface in the same institution We're on Epic, so we have Kaleidoscope. So all the sexy population and health things that everybody else gets to see, we don't see them, right? So even those like dashboards and that understanding that should be apparent to me as a provider, I have to kind of dig for that. And my life as a provider is already what it is. So am I really gonna like dig through those pieces to be able to figure that out? But I think those are the easiest things. It's just like you have those, every institution has those data. Every private practice has kind of data, right? Like where people live, who they are, like those kinds of things that are already available. So I think that part is the easiest. And then identifying if the data you need is helpful, right? And or if there's another piece of data that you can collect alongside the other things that you're already collecting, just to see if you're doing a good job. I think it sounds easy, but I think it's really, really, really challenging. But I think that's probably the lowest hanging fruit, is trying to figure out, how you stratify. And then for us, there's also a lot of pathways to be able to get an eye exam. And there's a lot of pathways to get the results of your eye exam back. And then there's a lot of holes, a lot of gaps in terms of what happens next. We're doing some focus groups next week with some retina specialists to try to ask based on the PAT survey. So the PAT survey is a survey of retina specialists ASRS does. So they did one last year, and they had first time 2 questions on like social terms of health and underserved populations. And so we're going to do some follow-up with our retina specialists to try to figure out that too, because a lot of times our colleagues that think about diabetic retinopathy screening don't think about what happens next. They're just happy we got you screened. But for those of us that deal with the blindness aspect of things, screening is just the first part. Like you have to figure out all of those in between pieces and how to get people back every month and all of those other things that are also complicated. So I think that too is like, how can we all kind of talk and share about what processes we should put into place to connect, even in our own institutions? But what is that? Job security and a lot of fun? I don't know. Glutton for
That's great.
punishment.
That's a great concept. Connecting everybody is really important. Christine, go ahead.
Yeah, hi, Kristen. Great presentation as always. I did have a question about, how do you make use of the patients that you, in the beginning of your talk, was a great A1C, and they're just, so fired up about coming to see you every year to make sure everything is fine. With what you're doing, how do you make use of those patients if you do already, or if you have plans to? Because, one of the conversations that I have with some of my patients, and not just eye health, actually just had a conversation yesterday with a male patient of mine who is an advocate of good health and just staying on top of things, that he makes his business to go out into the community and convince other males from our community to go get their colonoscopy, to go to the eye doctor, to even go to the primary care doctor. So in what way have you utilized those kind of foot soldiers in the community?
Sure. I mean, in science, we call it like positive deviance, right? Like considering the circumstances you're in, this should have, could have, would have been different for whatever reason, right? And we haven't. Like at first, in our first cohort, they were actually mostly from Philly qualified health centers, but most of them had eye exams because they have co-location.
Mm-hmm.
And so we did a bigger study, which is in review now, where we were looking at normal usage, which is what you were saying, right? It's like, okay, we looked at who's falling off, but what about the people that do it every year? Like, what can we learn? Like, what are characteristics of the folks that actually, love to come and they want to come take an eye picture every year, every day, right? So currently we have a multi-institutional study. We're working with Penn to do qualitative interviews with those humans. So you're saying, like, what do we do with those data? We're trying to figure out how to elevate those data, and not only get the stories of people that have trouble, but also get the stories of people that love coming and love like their health and like want to be ambassadors and like, what are the keys? And so our med student now, who's fabulous, she's going to be applying for residency in the fall. Her name is Julia Fu, but she did the big data study where she kind of looked at the source data and said, okay, who is following and why? And then now she's doing that sequential study where she's asking, okay, of those people, what are the themes that they have? Are they the same? You know, and I talked in the beginning about how that's what I've been nerding about it lately, is like this synthesis of all these stories and all these themes. It's like, I have this picture, I have this picture. Can we conceptualize that in a way that will influence what we build? So she's doing that. And I think that is great. I also met with a group recently, and the name is escaping me. He is, and I'll have to send it to the group because this is unfair to him. So a photographer that lost his vision from glaucoma, and he's a New York Times photographer. And I just recently talked to him and his team about his journey and wanting to be an ambassador. And Kira is familiar with him and his story. And, you know, I think we don't have a place, we don't have space. And I was bothering Jeff and Kira about this, about like, what are the places and spaces? And they have those beautiful training programs about how to make sure people can be trained to be ambassadors and advocates. And I think that's probably the best opportunity, individual opportunity that I've seen, is like their boot camp for how to be able to do that is probably the best individual opportunity to be able to say, okay, I like to be an ambassador. Here are some things, and here's how we train to be able to do that. As a corollary to that, though, I would love to be able to have a mixed community where like people that are doing well and they're super into it, and people that are not doing well and aren't super into it can have almost like a community of praxis, right? Like that they can almost like grow and build together in a way that I wouldn't be able to do because I haven't had that experience. So yeah. Oh, good. Jeff put in the chat. Perfect. Yeah. So if you have an excellent patient, I think that's a great opportunity to be able to leverage, to be able to tell those stories in ways that are meaningful and helpful beyond that one-on-one interaction.
And I'll put the link in the chat for Russell Frederick. He really has.
Oh, yes, Russell Frederick. Thank you for the name. I'm like, oh my God, I'm like dead. I can't.
Yeah, he's a great guy. So
great.
we made that connection.
Awesome. So I wanted to let everybody know we still have a few more minutes for questions, which we'll take here. I just want to let you know that we're having another spotlight on the 13th of March, where we're talking about the Vision Eye Health Surveillance System. There's some changes towards that. I'm talking about economic evaluation of vision loss in the United States. So please do stay tuned to that. But Hussein, why don't you ask a question here?
Oh, yeah. Thank you so much. First, thank you for invitation. I'm joining the first time for me to joining the Vision 2020, and I'm going to mark my calendar for the next one. But my question is regarding as a researcher working on the community engagement in URMC with Dr. Ramchandran. We are going to bring the community engagement and implementation to eye health and vision health. There is no research done before, or like there is like just few of the research that are working on the community engagement. But my question is, since again we want to bring the communities for the eye health project and research in URMC. My question is like, what is the best, or I can't say like, what is a good idea you have based on your experience to bring the communities in your research in eye health and maybe vision health? There is like a couple of, I mostly using the CBPR, community-based participative research, to bring the community to the especially the health research, and moving from one way as a community is one way, academia, expert, different way to be as a one way to create a new solution for eye health and like let's say vision health. But about your experience about the community engagement and implementation, what do you think the best idea or best way to bring the communities in kind of vision and eye health to create the trust, especially trust for the communities, how they can trust us more?
Yeah, I mean, I love this. And you see that when I was talking about community engagement, that was the highlight, because I think that's the hardest piece. Like it's the hardest piece, particularly if you want to engage minoritized communities, because the history is not great for institutions to have been good neighbors. But, my work that I've done in clinical trials teaches us that not to let the history stop us, right? Because there's some studies that demonstrate that, a number one difficulty that people were having with engaging in clinical trials was that people didn't ask them, right? And so it wasn't that they had this like hang up about all these other historical things that nobody ever asked. And sometimes people don't ask because they're worried that all these other things will come up. And so I think like that's the first thing. I think too, and the University of Rochester probably has this, it's great to tap into a partnership that already exists. So if there is like a steering committee, or if there is like a community advisory board that already exists, try to get on their calendar and then just get their initial thoughts about what you're trying to do. A lot of times you can find an ambassador and an advocate in those spaces that has somebody with eye health problems or that has diabetes and is really interested in kind of advocating on your behalf. I also would say, because of the way that diabetic retinopathy manifests, patients are great for that too. Like, so I leverage some of the relationships that I have with some of my patients and really receptive to like, do you think you could help us? I don't think we're getting this right. And I think that when you're saying it that way and when you're coming with like that humility, that's like, look, here's our data, we gotta do better, then people are really willing to help. I mean, we were surprised, even our infrastructure for like trying to compensate our participants, and we just had so many challenges. But our participants were so invested in trying to support and trying to be a part of what comes next that they were willing to, participate even free, which I don't believe in. You have to pay the participants. They got their money eventually, but it was very late. But I think even that, they were willing to just say, I care about this. You all are great. I want to support because I think that I believe in what you're doing. And that was pretty quick, right? Like it didn't take too long to do that. But also the other thing I would say is you have to keep showing up. And you're gonna get like the side eye, you're gonna get like nobody there, like right, all that stuff is gonna happen. And because you have this historic connection, you understand the background, you're just going to keep showing up. And eventually somebody's going to say, these guys keep showing up. And they'll start talking to you. And
right.
be like, right? They'll be like, I guess I better say something. They're here every month or every quarter or whatever is available to you. Eventually they'll be like, you're not going to give up, are you? All right. Let me see. And so like that trusted messenger and finding that trusted messenger, but also showing up with integrity about like what you're doing and what the possibilities are. And if you can, try to make a sustainability plan for a long time so that people know that like, oh, like we're planning to be here. And it doesn't have to be here, because there are places and spaces that have history that you won't be able to go, but like, we just want to be close by. And here are some things. I think the last thing I will say is, two things. I always say, if you don't have trust, try cash. So I think that helps, right? Showing up with proper resources and compensating people for their lived experience is really important. So I think that part is good. And then I'll also say like that give to get is good. So like if you're a good listener and people are saying, I want to hear about, so for us, we called Sing Together because some of the themes that we came out of our digital health tool buildings that people wanted to not only be in a digital community, they wanted to be in-person community. And so we built a couple events that were just based on what they asked for, right? So I brought an endocrinologist to sit in the back and talk to them about their problems and why their A1C kept changing and what the diagnoses were and those kind of things. We're going to do a dietary event for them because that's what they asked for, and fortunately I have the resources to be able to do that. But thinking within your wheelhouse, right? Like you're an expert. Like if you just show up for an hour, that's actually a big deal. They want to know about cataracts and glaucoma. I tell them I make glaucoma, but I at least know the basics. So I think those are the types of things, and leveraging the resources that you have to be able to support some things that community that they want to see and they want to do, and then they'll say, there's that guy again. And which is
Right.
helpful.
Showing up is the key thing, right? You want to show up, and that's so key.
Keep going, and it changes.
Keep going. Yeah.
I have a anecdote for 1 minute. So I had a med student that I wanted to do this, and she kept showing up, and like the lady who was running the venue, I'm like, I'm sure this lady just is not with it. And I'm like, we had this whole program, and she's like, oh, she gave the space, but the space she gave us was like back in the corner, and she said she's gonna send it out. She didn't send it, and I was like, don't worry about it. we'll just keep, we'll keep showing up. And so we built this whole program and just wasn't successful. Turns out we moved it next door, 30 people, right? Show up and it's already built and it's the same people, right? Like, so sometimes it's like that. It's just like, oh, you just, because if you've seen one community, you've seen one. So
Right.
sometimes it's just kind of like, we'll try something else. We'll figure it out. It's like
Yeah.
science.
Right. Well, these spotlights have been Dean and mine, baby, and we've been trying to get people to show up. So thanks for showing up, Kristen, and doing this, and thank you for honoring us by your awesome lecture and insight into this issue. I hope we take a lot of this back to our own communities and develop this. And if you all are going to be at Arvo, please do come by. We're going to have actually a Vision 2020 USA meeting on Sunday evening, so we'll send that invite out. So if you guys are in Denver, please do come out. And then on Monday, we're going to have a special session during the conference. So I hope you guys come out and listen. But I'll leave you all with the Friday evening. And thank you so much for joining us today. This is going to be on our YouTube channel. So do look out for it. And please do give feedback and comments and support Vision 2020 USA, which is the largest coalition actually of all vision champions in our country. So we're really excited to have you, Kristen. Thank you again for your time and look forward to seeing you on the 13th of March.
Yeah, thank you for the space. Excited about Arvo. I'll definitely be there.
Sounds great. Thanks, guys. Take care. Have a good day.